November 1st, welcome to our SSF Journal Club. Fantastic privilege to have our University of Maryland colleagues here again. They did an outstanding Tuesday evening interesting case conference just a week ago, and we're particularly grateful to SpineArt for sponsoring this and for our colleagues from the University of Maryland to take on another interesting topic, surgical management of isthmic spondylisthesis. And we have the esteemed Dr. Steve Ludwig take the lead and introduce your group. Thank you again, and welcome to the University of Maryland.
Thank you, Jens, and once again, thank you, Corey and Jens and the whole Seattle Foundation for allowing us to participate. This is really one of our favored events to do with our fellows, and we really are appreciative of everything you do for us as well. We thought we would choose, when Dr. Crandall and I had spoken about different topics, we had thought that we wanted to pick a topic that was sort of ubiquitous to all spine surgeons, right? And it sort of spanned the gamut of patient from a pediatric level to an adult level, right? Isthmic spondylolisthesis. And they pose, often it's an obvious diagnosis, but it can pose a clinical dilemma in how we choose the right procedure for the right patient. And all clinicians have their own algorithm, whether or not you treat the lysis itself, you do a fusion, how we do a fusion. And we thought we would go through 3 cases and 3 articles that support the approaches that we took, spanning pediatric spondylolysis to a salvage case. Ken, any other thoughts regarding?
Thanks, Steve. Thanks, of course, to the Seattle Science Foundation as well. I think that you guys do an excellent job with regards to education, and I agree with everything that you said, Steve. I think that this is a challenge to determine what the best course of action is. And there's often cases that I don't necessarily know what to do, and often I present this at our spine conference that we have, or present it to some of my partners to see what their management options would be for some of these cases, especially in younger patients. So I'm looking forward to having this discussion today. So which one of our fellows is planning on presenting the first paper?
I will. So yeah, we'll start off kind of in the realm of pediatrics. So it was a 17-year-old male. He's in high school with a chief complaint of low back pain. He's a competitive lacrosse player, and he's currently in the process of trying to earn a scholarship to play Division I lacrosse. His symptoms have been going on for about 18 months, but they've worsened over the past years. He's attempted to treat the pain with rest, PT, a bone stimulator prescribed by an outside physician, bracing, Medrol dose pack, as well as an injection, and his symptoms continue to worsen, and it is definitely, his symptoms are exacerbated with twisting and extension moments. He's a healthy kid otherwise, and an unremarkable physical exam. Here's x-rays obtained in clinic demonstrating an L5 pars defect without significant spondylolisthesis seen on flexion and extension views. No significant degenerative disc disease as well, and no coronal deformity seen. You have cuts from his CT scan on the next slide, which demonstrates the bilateral defect of the pars close to the facet joint. And I think there's another cut of the axials demonstrating the bilateral nature and some sclerotic bone at the site of the defect. And then an MRI was also obtained. There was no disc disease, no evidence of facet disease as well. And on that last cut, you can see some increased signal within the pars, which sometimes is not necessarily able to be seen on MRI imaging, but no other pathology was seen on his MRI scan. So this is kind of the case that we're starting with.
So Evan, let's stop there just for a second, just to get some thoughts from other folks. So once again, we often all see all levels of athleticism, right? This is a true collegiate level or allegedly collegiate level, right? D1, you said, athlete that was coming into college, probably scholarship dependent on his ability to play, etc. And we're often faced with these sort of clinical conundrums. You know, I often talk and try and get into the granular details because he's got back pain. It makes sense. His history, his physical examination correlate, with his advanced imaging studies. We know the diagnosis. He's tried bracing, rest, right? I always ask the athlete about the rest and the bracing aspects of things, because what I find more often than not, and maybe Jens can give some clarification, or other folks, Ken, is that they wear the brace sort of half-baked, and they're not necessarily compliant. And rest and bracing means rest and bracing, right? I usually tell the kids that wear the brace during the daily, activities. You don't have to wear it at night, a nice anti-lordotic brace, and we rest them. They don't need to be a couch potato. They can go to school, but they don't participate in sports, nothing. I rest them for 6 weeks. And often I find is that the kids were not compliant. They did not wear the brace. And that could be a source of failure for a problem that more often than not does not need surgery, right? And our goal is to save them surgery, I think, in my mind. I don't know, Jens, if you have any sort of pearls of wisdom regarding that, or if you find similar things on the West Coast, any thoughts about that?
Great point, great case. The simplest cases often invite the biggest discussions. Well said. The first thing we need to identify is what's the motivation, what's the story of this particular person, and especially whether they're student athletes or pro athletes. They have agents, they have their college scouts, they have scholarships waiting, they have a timeline, and the thought of resting for 3 months is not appealing. They also don't want to get tagged or marked with having a bad back. The true incidence of spondylolysis in high-performance athletes, certainly in certain positions, is very high. The main thing that we need to look at is there an L5 radiculopathy? I just saw a patient with this with a large disc herniation. And if they have an actual disc herniation, or if they have a true radiculopathy, that changes it. But otherwise, being aggressive about trying to localize, I still get bone scans. I'm curious to see what your evidence paper says. I still like plain CTs to see the bony morphology and flexion extension films you've gotten. And I try to educate them. I try to hamstring stretch, isometric abs, and modified training units. Electrical stimulate, I don't know about, but we've used it here, and I'm using it right now on a quarterback. And it's a really difficult subject. Aggressive injections of the PARs can get them going and get them moving into the season or into their scholarship eligibility trials. And again, I'm sure you'll go into the surgical treatment next, but this is a frustrating subject because it has a high degree of recalcitrance. Thank you for asking me.
Ken, any other thoughts to add to that with regards to your workup for these kids before Brad goes over articles and what we did?
No, nothing else specific. I mean, I think that you both hit the nail on the head in terms of workup and initial management.
Great. Go ahead, Brad.
Okay, so the article that we're going to discuss was out of DuPont, Dr. Shaw and Gabos, where they were comparing two surgical techniques, a laminar compression screw as well as a pedicle screw hook construct in adolescent patients. And if you keep going, Rohan, just in kind of an overview of the article, it was a retrospective cohort study. The surgeries were performed over about a 12-year period from 2000 to 2012, and it was mainly looking at clinical and radiographic outcomes of these two surgical techniques. As I mentioned, a laminar compression screw, which they called LS, as well as a pedicle screw rod and laminar hook construct, PSRH. There were 9 and 7 patients in these groups respectively. All of the patients were under 18 years old. For their clinical outcomes, they used the McNabb criteria to kind of determine whether or not a favorable outcome, which was considered good or excellent, was achieved in the patients, and then used either X-ray imaging to determine healing versus CT when it was needed for persistent back pain or equivocal cases. And they did note the few complications that they did have. So if you keep going, as the criteria over this time period in terms of the patients that underwent surgical intervention, it had to be radiologically confirmed spondylolysis with or without just a grade 1 spondy. So there was no significant instability in these patients. Chronic low back pain, which they determined was greater than 6 months. No neurological symptoms, no radicular pain were present in any of the adolescents treated. The conservative management, they didn't go into the exact specifics, but it consisted of rest, physical therapy, and bracing. They all needed to fail these treatments in order to be considered for surgical intervention. And then MRI had to have no disc or facet pathology. All the patients in the study did subsequently undergo both diagnostic and therapeutic injections of the PARs, and they all did experience symptomatic relief from these. And then, as I mentioned before, they used CT in the equivocal cases to determine whether or not these patients had fused. The laminar screw technique was in a more minimally invasive fashion. What they described as very similar to a Wiltse kind of paraspinal approach to access the PARs before using a 4.5 millimeter cannulated screw to achieve their fixation. And they did use posterior iliac crest autograft within the screw to enhance bony healing. And then the pedicle screw kind of was a very standard open exposure of the level to be operated on with a pedicle screw and an infralaminar hook to achieve compression with a rod. I think next slide, we just have 2 examples that they provided from their study of their surgical techniques. We can get into the results. I think you skipped one there. Yeah, so on the top is the laminar compression screw cohort, which consisted of 9 patients. The bottom table is the pedicle screw hook group, 9 and 7 patients respectively. As you can see, all the patients were under 18. Majority of the pathology was at L4, L5. And you can see all patients did achieve fusion, which was confirmed radiographically or CT. Overall, the time to fusion did seem to be more quick and expedited in the pedicle screw group. But as I said, all patients did achieve fusion in the laminar compression group. The pedicle screw group did on average tend to return to sport slightly more quickly. As you see, there's a couple that returned in 3, 4, and 5 months respectively versus 6 or greater in the laminar screw group. Hard to pinpoint why that exactly is. Depends on the child and the sport that they're returning to, but that did seem to be the trend amongst those 7 patients. And then in each group, 8 out of the 9 and 6 out of the 7 had either a good or an excellent outcome according to the McNabb criteria. So all these patients really did do well and did achieve fusion, as you can see from this. And then kind of going into more of the specifics of the surgery. Next slide, Rohan. I think from the top table, the most interesting statistics are the return to time to sport. So you can see on average 7.7 months in the screw group compared to 5.9 months in the pedicle screw group. And then somewhat as expected, just in the more invasive nature of the surgery in the pedicle screw group, they did tend to stay in the hospital longer and did have more blood loss during the surgery, although it's difficult to determine what the clinical significance of this, but it's somewhat expected based on the surgical technique and implant density. Keep going. So kind of overall, this paper at the time was kind of one of the larger cohorts to describe these techniques, and overall, they both appear to be very effective and safe methods of obtaining fixation. In terms of the complication profile, and the only 3 reported complications were in the pedicle screw group. 1 was a mild sensory deficit that resolved within 6 months, and then 2 had what they called superficial wound infections, which was treated with oral antibiotics and resolved without any further complication. Almost all the patients returned to sport in both groups. And kind of looking back, as we determined that both of these surgical interventions are effective, you kind of need to take a step back and realize all these patients were under 18 years old in that cohort of group that are going to be more likely to heal. So these kind of are the ideal patients to hopefully return to sport. And you look at the limitations of each technique, in the paper as a whole, it is retrospective, and there was only 9 and 7 patients in each group respectively. So it's hard to draw broad-based conclusions. And I think there are some limitations to the laminar screw technique, as you're somewhat reliant on the patient anatomy and getting in a perfectly placed screw in order to achieve that compression and appropriate fixation to get to healing. But overall, I think this is a great study and kind of shows the benefit of each intervention.
Thanks. I mean, I think that's a great overview, and I think that particularly in young patients, we're looking for these options that can avoid fusing a motion segment, and these provide two different options. One of the challenges, I think, of the laminar screw is that it's a technique that a lot of us don't perform, on a regular basis. So there's certainly a learning curve to performing that technique. And like you mentioned, it's highly dependent on the anatomy. And sometimes I've seen patients where I've thought about doing it, but then the fracture, segments of bone don't completely line up, and I don't think that I could get a screw to traverse the fracture appropriately. But I wonder now with new navigation tools as well as robotics and everything, whether or not that's going to be a more feasible or easier to perform technique.
Yeah, I think those are all great points, Ken. And I don't use a lot of enabling technology. I'm a believer in enabling technology, but I typically don't use a lot of robotics. But this may be a really, really good indication for that. I think the magral technique, the pedicle screw with the hook, is mechanically stronger, right, than the AO screw that's put through the pars, right? And I think because the mechanics are so much stronger, Brad, that's probably why the return to play criteria was a little bit, I think 2 or 3 months, sooner, right? And it may be irrelevant, and you may not be able to, to really make really formidable decisions. But I think that probably plays a role in this, right? It's like everything else in medicine, right? There's a lack of evidence, right? But this is evidence to support this technique.
Can I interject for a sec?
Yeah, Charlie, I'm sorry, I didn't see you.
Yeah, no problem. There's a great talk that Rick Sasso gave at the spine section last year, and it was I think, a clever way to deal with this. Basically, you take a cervical instrumentation system that has large diameter screws, and you do a pedicle screw with one of those cervical screws, let's say, 6.5, 45 screw that you put in, but it has a cervical head. And then you take a standard cervical screw, maybe like a 4.016 or something, and then you do that to span the pars fracture. And then you can get a pars screw that hooks up to the thoracic pedicle screw, but that's in the lumbar spine. And you have like a rod that you can connect, a polyaxial head and a polyaxial head that you can compress across, or, and they're small heads, so you can put some biology around it. I thought it was a clever solution, better than the hook, I thought.
So Charlie, you have enough polyaxial range of motion in those heads with Rick's technique, we'll call it the Sasso technique, to span the rod and connect and deliver the biology and compression through the rod member?
Correct.
Yeah, that's amazing insight.
Yeah, so basically using the cervical system in the lumbar spine, and you take advantage of the small heads, and you take advantage of the TLIF heads, and and you have like cervical screws now that can be like 6.5.
Yeah. I always question what's the right biology. I never want to go back. I've done a handful of these cases because they're not very common, as sort of Jens intimated. But I'll use an extra small BMP with some allograft bone just to get it to heal. I'll burr it, I'll decorticate it. I do it through a midline approach, and I put a little wrap of the extra small BMP into the pars defect that I've decorticated. and then compress and I'm done. That's sort of my biologic of choice.
Right.
Why don't you show us, Evan, so we can move on to the next case? Why don't you show us what we did?
Yeah, so going back to our patient, he ended up getting the pedicle screw hook construct, almost exactly as described in the paper. Use of some intraop fluoro shots. BMP, I believe, was used after debriding the defect. And then the patient went on and did very well. These are his immediate postoperative films. We have 5-month post-op with flexion extension views, which demonstrates union of the defect.
Yeah, that's a great case. I think the key to this case that everybody should take home is that in the absence of disc degeneration, a significant listhesis, anything greater than maybe grade 1. I mean, I've done this in very low grade 1, half a grade slip, with a pristine disc space. I think this is the go-to. The issues, with regards to, and Jens alluded to this, if there's an associated disc herniation with a spondylolysis, there's a grade 1 slip, the disc appears to be, lost its hydration status and appears degenerated, however you want to define that, then you're probably looking at a fusion at that segment, unfortunately. That's just sort of our algorithm. Any other thoughts, Jens, before we move on?
Great case, and I like this solution, and I've not done the, quote, Sasso technique. Rick would be the first to deny responsibility for that, but he's such an elegant surgeon. The main point that I have learned is this zone of lysis is very different. The article alluded to that. There are patients with a very atrophic, large destruction zone that's completely sclerotic and walled off. The people who have a unilateral break, where the screws might be a very amenable technique. And then the people who have a relatively fresh fracture that's still hot on a bone scan, where maybe less of a fusion effort is necessary. This is my go-to technique. You have to resect this pars defect when it's dead, I use the same incision, autologous corticocancellous iliac crest graft that I wedge in between there after I've resected the dead zone. And this is a very strong construct. The rod bend is unique. I'd call that the Ludwig bend. But because the modern hooks, you have kind of an offset, so you can kind of make it less curvy. But this is robust, this is strong, and this allows you to do nice carpentry to actually put in a living piece of bone into that gap zone. So I totally concur, and this is nicely done.
Hello, team. So a couple of things for this case that I thought was useful. To get the bend of the rod, I used a small stature system, meaning a 5.0 millimeter rod instead of the 5.5, which was easy. And the other point important, if you don't mind going to the CT scan, the preoperative CT scan, is that the pars fracture actually extended it into the 4.5 joint. So then this young guy can end up with pathology of 5.1 if it slips, or 4.5, which was why I was debating what to do, especially in the image to the left. So it is extending to the 4.5 joint. So I think it's a hard problem for him to end up with an L4 to S1 fusion potentially down the road.
Great, thanks, JJ. Why don't we move on to the next case, guys?
All right, next case. This was a 52-year-old male presenting with chronic low back pain, ongoing for the last 15 years and worsening over the last year, affecting his ability to play golf, which is a surgical indication right there. He'd failed conservative treatment, including physical therapy, pain meds, injections. He had 100% axial pain, no radicular symptoms. He had diabetes, he was a non-smoker, otherwise healthy. On exam, he had full strength and normal coronal and sagittal alignment with decreased lumbar range of motion, which exacerbated his axial symptoms. These are his upright x-rays taken in clinic, demonstrating severe degeneration of the L5-S1 disc space with bilateral pars defect and spondylolisthesis, grade 1, 2-ish. A CT scan just re-demonstrates that. The images to the right, you can see that posterior osteophyte off the body, making that hook, which raised concern of the nerve root being entrapped in that, and whether it need decompression or not. But we got an MRI and showed that the
next slide, Rohan. That the nerve was posterior. And so stopping there, we'll move on to the paper. This was a study out of Harvard published in Spine in 2022, looking at ALIF versus TLIF for L5-S1 isthmic spondylisthesis. And the one-liner's in the title there, but we'll go through it here. So previous literature suggests that ALIF and TLIF have clinical equivalence. And this is from past articles that showed no difference in fusion rate or clinical outcomes, but the clinical outcomes many have looked at are just VAS scores or OSI. Whereas the study was done because a robust comparative study looking at radiographic outcomes and PROMIS scores was lacking. And so this compared segmental and regional radiographic parameters between ALIF and TLIF, compared clinical outcomes using PROMIS scores, and then assessed changes to these parameters over a period of time. This was a retrospective cohort study done at Mass General between 2016 and 2020, looking at single level L5-S1 interbody fusions for isthmic spondylolisthesis. Had 70 total patients, and the final follow-up was average over a year. So these are the radiographic parameters they looked at 3 time points: one pre-op, then the first post-op visit, which was less than 6 weeks after surgery, and then the final post-op, which was follow-up at least 1 year after surgery. And so they looked at the segmental lordosis at the 5-1 level, as well as the L4-S1 lordosis, and then the entire lumbar lordosis, as well as how the lordosis changed at the proximal adjacent levels, as well as disc height and anterior listhesis, and then the clinical outcomes were the PROMIS scores. So looking at the radiographic results, ALIF was found to have significantly greater segmental lordosis, L4-S1 lordosis, and disc height increase at both the initial first post-op and the final post-op visit. The segmental lordosis difference was pretty significant, almost 10 degrees versus 0.2 degrees, comparing ALIF and TLIF, as well as the significant increase in the disc height between the two. And then next slide, if we look at the differences or the changes that occurred with time, the TLIF group had the disc height significantly decrease due to subsidence, but it was maintained in the ALIF group. The ALIF group also showed increased lumbar lordosis with time, and there was an equivalent reduction between the two techniques. Then looking at PROMIS scores, just over 50% of patients completed both pre-op and post-op PROMIS scores. Both groups had improvements in their pain, but the ALIF found additional improvement in physical function, whereas the TLIF group didn't show any significant improvement in physical function scores. So key takeaways is, ALIF demonstrates superior radiographic outcomes that is sustained over time. So that's on average, based on this study, 9.4 degrees more segmental lordosis, more disc height that was maintained over time. And it also had, showed improved physical function, whereas the TLIF only had improved pain scores. And so, obviously there are other patient characteristics that may, affect your decision, patient anatomy, access to a vascular surgeon, et cetera. But this thought it was a good study looking specifically at, single level L5-S1, as well as kind of how these parameters change over a period of time. Granted, it was only 1 year. I think it still was pretty significant differences in the alignment.
there's no question in my mind, you know, an ALIF compared to a TLIF. I mean, everybody who's part of this discussion group knows, even at the fellow level, the ability to take the disc out to restore the height of the disc space, and to deliver a bigger, larger footprint of cage is far superior with an ALIF compared to a TLIF and even a PLIF. Even the greatest PLIFer in the world will not achieve, I do not believe, in my humble opinion, as good of a job as an ALIF. And this data set sort of supports that, right? And the one thing in my algorithm that, you know, I decide whether I'm doing an ALIF versus a TLIF is really the sex, and I'll tell you why, male versus female. It's their body habitus, underlying vascular disease, previous abdominal surgery, all that plays a role, right? In whether or not you choose anterior versus posterior. If a patient's BMI is significantly high, I define that as greater than probably 35. If there's significant atherosclerotic disease, you know, calcifications on their aorta, and if they're a male in the sort of child rearing years, I always get concerned about the rare but significant issues involving retrograde ejaculation. And people can argue that may not be an issue with modern techniques, retroperitoneal approach, avoiding the use of electrocautery. You know, getting the hypogastric plexus and having a retrograde ejaculation is rare and rarely a permanent issue, but it can be an issue. So those play a role in the decision making. This gentleman, 52, male, no peripheral vascular disease, normal BMI, you know, is still a candidate, but it's sort of, I always get concerned and at least have that conversation. I don't know if anybody else has any thoughts on, even though the paper supports the virtues of an ALIF versus TLIF approach, I think you just have to take everything within a clinical context.
I completely agree with you, Steve. The only other thing that I'll add from my own personal bias is if they have really, really severe stenosis, either central stenosis or foraminal stenosis, it probably biases me to do a TLIF over an ALIF because I know 100% that I'm decompressing the nerves as opposed to just relying on indirect decompression.
Yeah, I mean, does stenosis, I'll ask Jens, it looks like he was reaching for the mic, and I'll pose this question. Does the degree of stenosis matter? If patients' predominant symptoms are back greater than leg, neurologically normal, which most of these people are, does the degree of stenosis matter if you're able to, you know, improve their lordosis segmentally and locally, and indirectly decompress the nerve, open up the neuroforamen? Does stenosis matter? Back pain greater than leg pain, or even alternatively, leg pain greater than back pain? Does that matter to you?
So this is, I think Dr. Crandall raised a very good point. In my hundreds of isthmic spondy cases that I've done, I've always been amazed how resilient human beings are, because I wanted to say crap, but I'm not going to say that the stuff that is formed there over the years and decades frequently, that's pinching the L5 roots, that's deforming them, is truly amazing in terms of how well we function despite that stuff. And depending upon the amount of stenosis, cleaning that up from the backside where the main pathology is essential, and hoping for an indirect reduction is a possibility. Again, it depends upon the circumstances, but for the most part, all comers taken, a nice decompression and a proper release and a proper reduction after the full decompression has been achieved is my clear preference. I think this study again shows the key points of that a lot of people think it's easier in their hands, and I agree with that an ALIF restores an intervertebral body height better. In terms of the problems, again, I have a revision practice here. I see a lot of failed ALIFs after isthmic spondies. The devil's in the detail again, and how well you do that and how mobile the spondy is. In general, again, a simple TLIF, which I see a lot done in the communities, where a single cage is just jammed in there without much of a disc prep, you're going to have not a good alignment result. You're not going to have good bone healing. So the devil's, again, the detail and how well you do your posterior release, your posterior osteotomy. We like these intradiscal osteotomies. It's a great application for that. A proper reduction, and then putting in ideally 2 expandable cages, one left and right on the apophyseal ring, to have a really good lordosis. You can literally dial in what you want from posterior. So that's my preference. But I think this is a good study in terms of showing that for all comers, probably an ALIF restores better alignment. It's, quote, simpler in most people's hands. Amir, what do you think?
So again, thank you guys for the great summary. As you mentioned, I think ALIF is not, quote unquote, an easier surgery. I think, as you mentioned earlier, in the right hands, I think this can be done equally well with a TLIF or an ALIF. Here we do both approaches, and I think absolutely, if you look at the kind of bigger picture, and all patients, all different variations of the TLIF technique, absolutely, I think this shows that ALIF is a better, generally, better alignment, and the clinical outcomes are not really deniable here, but I think when done appropriately, you can get equally good results with a TLIF. And again, we are big fans of the intradiscal osteotomy. And in a lot of patients, you're not able to do an ALIF because of a lot of reasons. And having that technique in your back pocket to be able to get good clinical outcomes, I think is very important. And yeah, totally agree.
Say, Rohan, can you go back to the CT? I just wanted to ask the group, when you have that posterior hook of an osteophyte in a patient like this who doesn't have any radicular symptoms, how are you, managing that if your plan is do an ALIF? Is it do the ALIF if there are any neuromonitoring changes, then you'll decompress as opposed to just perking the back? Yeah, just, when you restore the height and the nerve root can get tented right there. Just curious how people are going about that.
So I'll just jump in quickly. I definitely, if I'm doing a larger reduction with an ALIF technique, I will use those neuromonitoring for the anterior portion. And if I am getting feedback, just stopping there, making sure that you're going posteriorly and then doing it open in a very clear decompression, and then getting the further reduction from a posterior approach. But unfortunately, sometimes you will not get any feedback, and patients will wake up with a radiculopathy.
I think you point out this bone hook is so important, and thank you for really highlighting that. And this is a very good imagery for that, because this is the nemesis of the L5 root. If you do a reduction, the L5 root will fall forwards and literally get jabbed by that. So this is again why I like a posterior procedure, because I can literally gently elevate the root and then with a curved osteotome knock that off. And when I've had postoperative radiculopathies and I've looked at my postoperative CT scan, I've left this hook in place. So this has been a big learning point for me, and again for me underscores a posterior procedure, because I'm not sure, and I do lumbar disc replacements, I'm not sure I can take this hook out reliably from anterior, and I congratulate those colleagues who can do that reliably.
Great. So Evan, you want to show the crowd what we did, or what was done?
There's a little GIF, and so the ALIF inner body. I don't know if you can appreciate it, but you can reduce through the implant. There's a little dial there, so got a fairly good reduction, and then just perked the back. He's doing great. And next slide's finals.
That looks beautiful, and that hook seems to have been gone. Guys, Dr. Vishal Khan has, Dr. Vishal Khatri has asked us, if you do an ALIF and this kind of a beautiful procedure and the patient still has severe buttock pain, meaning L5 pain, what do you do? How do you handle that then? So this is beautifully done despite your phenomenal efforts. What do you do and how you troubleshoot what's going on with presumed L5/buttock pain?
Yeah, I think it's not uncommon to, as you were inferring, to have postoperative discomfort and pain, and no objective deficit. And typically, it's a stretch phenomenon, and that's the thought. And if there's no significant objective neurologic deficit, and we treat the patient with cautious observation, and treat them with some steroids and time, and we don't ignore it, but we counsel them over time with the indirect decompression. Our hope is that things will cool off, and that's typically the case in the vast majority of our experience. It's very similar to lateral indirect, right? Decompressions, it's very similar sort of phenomenon. And it's exceedingly rare that you have to go back and do a direct decompression, but there's always that discussion that's had with the patient preoperatively anytime we're doing anterior indirect procedures, that there may be some rubric or calculus or clinical scenario where you have to go back. So if the patient's not responding over time, and they're just not moving ahead in a good direction, we would consider going back and doing a foraminotomy or an opening up of that area. Anything else, Ken, to add to that?
No, I was just going to ask you a question just about your practice. Do you always do a posterior fusion on every one of these patients?
So if I'm doing a ALIF related approach to a patient, 1 or 2 levels for isthmic spondylolisthesis, I typically will do the ALIFs at 5.1 and or 4.5. I will put structural cages in. I will use BMP. So I get the device in, the biology in through the front, but then I typically will put percutaneous screws through the back with no fusion. Sometimes in a host that's challenged, I'll add to the fusion, and my percutaneous approach posteriorly will create a Wiltse approach, as you guys know, and we could decorticate the TPs before we drop the screws in, and put bone grafting material in the posterolateral fusion. So we'll do that in a compromised fusion host as well. So that's sort of the algorithm for those folks.
But a standalone ALIF is not good enough. You don't
I
think?
will do a standalone ALIF for very low-grade isthmic spondylolisthesis when a patient does not have osteoporosis. So I will do a cage and a plate. I'm a big fan of a plate. I won't do a standalone with the integrated screws. I don't like that technology. I feel like the mechanics of the plating in the face of an already spinal deformity, albeit very small, non-osteoporotic, I'll do a plate. I will do in a subset of people, standalone ALIF with a plate.
Okay.
We just this last year revised 2 patients with standalone ALIFs with plates. So not to contradict you there, they were always
They were probably my patients, though.
No. They were truly West Coast patients, but to contradict you, it's mechanically clearly a problem. I think Dr. Crandall raises a very good point that having a posterior tension band in this setting helps a lot. And even if it's done percutaneously, that's a really big deal. But what you did here is beautiful.
Great. You want to move on, Alex, to the last case?
Yes. So this is a case of a 51-year-old female who was seen in our clinic for low back pain and bilateral leg pain, right greater than left. She had a history of a L5-S1 posterior fusion at an outside hospital about 1 year prior. She had a 5.1 isthmic spondy. At that time, she was having left leg pain and low back pain. Her symptoms initially improved for a few months, but then she developed quite severe right leg pain. She failed a long course of non-operative management consisting of physical therapy, NSAIDs, and injections. She had a history of breast cancer and prior abdominal surgery, hysterectomy. On exam, she had some mild weakness in her left lower extremity, and she had bad right leg pain with paresthesia in the L4 and 5 distributions. Unfortunately, we don't have her preoperative imaging from the outside hospital. These were the first x-rays we took in our system. So she has 5-1 isthmic spondylolisthesis, degenerative scoliosis, but she had good coronal and sagittal balance overall. She has instrumentation at L5 and S1. According to the operative note from the outside hospital, the initial plan was to do a MIS TLIF at this level, but after placement of the screws, the surgeon was unable to place their smallest cage into the disc space, and so they just packed the disc space with bone graft. On the next slide, we have just flexion extension views from our clinic that doesn't show any gross instability at this level. We got a CT scan, which is a video here that you can click on. So it shows about a grade 2 spondylolisthesis at 5-1 with a pseudarthrosis at this level. On the next slide, there's an MRI that shows really severe bilateral foraminal stenosis at 5-1. So the paper I'll be discussing is titled Comparative Analysis of 3 Posterior-only Surgical Techniques for Isthmic L5-S1 Spondylolisthesis. It was published by a group out of WashU in the JAOS journal earlier this year. And so this study was a single center comparative cohort study that looked at radiographic and clinical outcomes in 60 patients between 2000 and 2016 that had all posterior surgery, whether it was pedicle screw only surgery, an inner body device placement posteriorly, or transsacral screws. All of these patients had a grade 2 or higher spondylolisthesis, and they excluded patients who had a spondylolisthesis as a result of the trauma, or tumor patients, or people who had fibular strut allografts. In total, there were 16 patients who had pedicle screw only constructs, 20 transsacral patients, and 24 patients who had interbody devices placed. There was some heterogeneity between the groups. The pedicle screw only group was significantly older, with a mean age of 58 versus a mean age of 43 and 40 in the other two groups. There was a higher frequency of higher grade slips in the transsacral fusion groups, as well as more lumbosacral kyphosis and higher pelvic incidences. Their results, they all had similarly improved radiographic alignment and clinical outcomes. The pedicle screw only group did have a higher complication rate, 50% versus 15 and 16.7%. In the entire cohort, there were 6 reoperations, and there was only 1 pseudarthrosis in the transsacral group. On the next slide shows the patient demographics. Here you can see that the pedicle screw only group had the highest average age. In the pedicle screw only group, they also tended to have more levels that were fused, but this did not reach statistical significance. On the next page, it shows the various radiographic parameters. The transsacral fusion groups had higher grade slips. There were no grade 3 or 4, or sorry, 4 or 5 grade slips in the pedicle screw only group, and there were fewer in the inner body group. Those changes persisted at the last post-op visits. This is a table of their outcomes. So there was a statistically significant improvement in VAS and ODI scores in each of these three groups. And when compared between the groups, there was no statistically significant difference in those changes. The next page, this shows the complications in this cohort. The pedicle screw only group had the highest rate of complications at 50%. The most common complication was adjacent segment degeneration, which the authors postulated was because this group had more levels instrumented on average. And so the takeaways from this paper is that each one of these strategies can result in improved clinical and radiographic outcomes. The groups that had anterior column support, whether it be an interbody device or a transsacral screws, resulted in a lower overall complication rate, which is in line with the rest of the literature on this topic. The main limitations for the study is the smaller sample size of only 60 patients, and there was some heterogeneity between the groups in terms of their demographics and radiographic features. But in conclusion, this is further evidence that anterior column support is important when taking care of these high-grade slips, and that transsacral fusion can achieve good outcomes in patients with higher grade slips.
Yeah, I think, Alex, before you go and show everybody what was done, the transsacral technique to me is always been sort of a salvage technique for failed isthmic spondies in a higher grade slip, or alternatively a go-to in the right patient, for a high grade slip as the primary procedure. The technical nuances of this case are very interesting to me, right? Putting in really, really large screws that with a medialized trajectory that go through the sacrum, through the disc space or whatever is left of it, and then into the L5 vertebral body, give you really, really strong, robust fixation. So that's the advantage of it. And with stronger, more rigid fixation, right, hopefully that equates to, an improvement of their radiographic fusion outcome, and obviously their clinical outcome may or may not correlate with that. Whether or not you go to the pelvis is, to me, in the face of it depends on how high of a grade it is, as well, the slip angle, and most importantly, bone quality, because you're really putting that sacrum at risk for cracking and fracturing in half. So anybody that is at risk, this is a patient you're describing, female in her mid-50s, but yet has gone through chemotherapy, which is always concerning to me from a bone quality standpoint. They would get a DEXA scan looking at their bone health, and going to the pelvis to, as well, and somebody that's already failed a previously done attempted fusion. Any other thoughts from Seattle, West Coast colleagues?
I'm here.
Failed high grade.
I know. Can you go back to
posterolateral fusion?
This is a really important study and case. If you can go back to that last image of the case. So this is well said and well done. And that's, again, we do need an anterior column support. We do need to have a proper understanding of the pelvis anatomy in dysplastic sacri and people with very steep inclination angles. This is a serious problem, and again, understanding when and how to go to the pelvis or supplementing S1 screws with for instance, ALIF screws in more osteodense patients is a really big deal. So that's well underscored, and there is a subset of patients who are putting in one of those retrosacral Bowman-type grafts, usually done from retrograde through this S2-3 segment into L5, provides a reasonable option. Chris Shaffey and others have described the S1 screw going into the L5 vertebral body as an alternative, a supplement. So those are reasonable kind of salvage options. But in the end, when I see these failed spondies, it's similar principles all the time. Poor S1 fixation and poor reduction results with insufficient interbody grafting, incomplete reductions. Those are the basic principles. And again, this goes back to like in orthopedics, poor fracture care where no reduction was achieved, no healing was achieved, insufficient fixation. So same principles as in fracture care. It's a great case though.
Yeah, I think the technique that I use for the interbody graft, I'll do transvertebral screws, and then I'll take an ACL, a 12 millimeter ACL reamer, and move the thecal sac to the side and ream, put a guide wire across the sacral canal through the disc space into the L5 vertebral body. And then I'll ream a 12 millimeter channel with the ACL reamer under fluoro, take that out, and then I'll take a static harms-like cage. It doesn't matter, it's irrelevant which cage you use. And then I'll pack it with bone grafting material from the reaming, sometimes a little piece of BMP, and I'll slide it into that conduit with the transvertebral screws to get the biology right as well. That's just my technique of how I do it. But I look at that as it's really a salvage technique, which is what you need here. Alex, why don't you
So the next slide
and show us what we did?
So in this patient with severe residual foraminal stenosis and a pseudoarthrosis after a 5-1 fusion with the steep angle of the 5-1 disc space and prior abdominal surgery, we decided to do an all posterior approach. The plan was to try to place an interbody from the back and then be ready to extend up to L4 or the pelvis, depending on the fixation. And so on the next slide, these are the final fluoro shots. So after the old instrumentation was removed and a gill laminectomy was performed, the L5 nerve roots were found to be completely encased in scar with severe craniocaudal stenosis. The disc space was probed with a Penfield, and the spondy was determined to be completely rigid and not reducible. And so at that point, the decision was made to avoid placing an interbody device, removing the bilateral L5 pedicles to allow for decompression of the L5 nerve roots, placement of a transsacral screw. There's a 55 millimeter screw on one side and a 60 millimeter screw on the other side, and then supplement the fixation with bilateral pedicle screws at L4 with S2AI screws placed distally. So these are her 1 month post-operative films. She had immediate resolution of her leg radicular pain. And on the next slide, these are her 5 month post-op films. She's doing very well. She doesn't have any leg pain or weakness and only has intermittent and mild low back pain. So she's happy.
Great. Ken, any other closing thoughts?
No, I mean, I think that was a great case. I think that you did exactly what I would have done. I mean, I usually try to do something anteriorly, but there's clearly contraindications in a lot of patients, especially in Baltimore. But again, thanks to the Seattle Science Foundation. I think that this was a great overview of a complex topic. Thanks for having us, and we look forward to the next time that we can meet together.
So many thanks to you guys, our worldwide audience. We've had a great attendance this morning with great interest and a lot of chats going on. Thank you for your interactions. And this was a really good educational display. Dr. Randy Davis says thank you also, by the way. So always good to have you, Randy. And really, the articles were good, and the papers supported and added a lot of depth to the cases presented. So thank you, University of Maryland, and fellows and attendings. Thank you all.
Thank you, guys. Appreciate it.
Thank you.
Happy and safe November to everybody.
You too.
You too.
Take care. Bye-bye.
So we'll have to go down.